Maybe we can slowly start. So thank you again for joining us for this webinar. So I'm Maud Tusseau. I'm a molecular geneticist. I'm working in Lyon in France. So my work focuses on monogenic immune disorders. I have a great interest in the JAK-STAT pathway, so it's my great pleasure to be your moderator today. So we want this to be an interactive session, so please use the question tab and feel free to ask any question at any time during the presentation and the Q&A. So today we are thrilled to welcome 3 talented speakers. So for the first part will be handled by Dr. Marco Fischer from the Department of Allergology and Clinical Immunology in Children's Hospital in East Switzerland, and also in the Center for Human Immunology in the University of Zurich. And he will introduce the use of JAK inhibitors in JAK-STAT-related inborn error of immunity, with clinical examples, literature data, and HICT experience. Then we'll have Dr. Peter Olbrich from the University of Seville in Spain, and he will present the new consensus guidelines on JAK inhibitors in JAK-STAT-related conditions. And finally, Dr. Carsten Speckmann from the University of Freiburg, Germany, will chair a joint discussion including the use of JAK inhibitors in other inborn error of immunity. So welcome, Marco, Peter, Carsten, and everyone. And Marco, the screen is yours.
Thank you for hosting us today, and thank you for the nice introduction. I have nothing to disclose, and I will, as already mentioned, discuss the principles of the JAK-STAT signaling pathway, JAK inhibitors in general, and as well especially the use of JAK inhibitors in JAK-STATopathies. So first, the principle of the signaling pathway. The binding of the cytokine leads to conformational change of the receptor. This leads to the phosphorylation of Janus kinase, recruitment of STAT to the receptor, and phosphorylation, conformational change, dimerization, and this leads to a translocation to the nucleus. And this induced the transcription of targeted genes. They are critical for key host inflammatory response, such as lymphopoiesis, homeostasis, CD4 differentiation, regulation of inflammation, antiviral responses, hematopoiesis, and many others. We have there is 4 different JAKs known, and as well 7 STATs. So it has different family members, and they're tightly regulated. There is over 200 variants of both inactivating and activating variants in the JAK-STAT genes known, linked to different human diseases. This helps us as well better understanding the physiological role of this important pathway. Due to the time today, I will focus mainly on STAT1 gain of function and STAT3 gain of function. The clinical presentation of STAT1 gain of function is a heterogeneous disease with different manifestation. It contains infectious manifestations, most prominently the chronic mucocutaneous candidiasis, but as well other both bacterial and viral infections that can occur. It has as well a hyperinflammatory manifestation, so non-infectious manifestations, which can be organ-specific or add to a systemic autoimmunity in individual patients. In a big cohort from 2016, published in Blood, it was shown that the cumulative survival rate at 60 years of age is significantly lower in patients with complications, as you can see here, around 31%. There was as well the initial largest series of transplanted patients in STAT1 gain of function was published in 2018 by Jennifer Leiding, and it contains 15 patients with a primary donor engraftment of 74% of patients, with an overall surviving of just 40%, with a secondary graft failure of 50%, so a post event-free survival around of 10% at day 100. This is potentially due to the hyperinflammatory state of this disease. Only 1 out of 15 patients was treated with JAK inhibitor prior to HSCT. STAT3 gain of function showed a different manifestation. It is a multisystemic diseases. It can contain as well infectious manifestation, recurrent area infections, especially in patients with hypergammaglobulinemia. It can as well showed some viral infections, and mainly as well in patients with steroids and other immunosuppressive treatment. And it showed different non-infectious manifestation. The most prominent one are lymphoproliferation with 73% and autoimmune cytopenia with 67% overall. Overall survival in the big cohort published by Jennifer Leiding was around 88%. The overall survival wasn't affected by the age at first diagnosis, as you can see here. However, it was affected by progressive respiratory diseases lead to oxygen dependency, enteropathy, hepatitis, and total parenteral nutrient dependence. So this was associated with an early death in STAT3 gain of function patients. In this big cohort, 23 patients underwent HSCT, and the reported overall survival was at 62%. But let's speak about a particular patient. It's a 7-year-old girl, which is treated in Freiburg, and with 4 years of age, she had recurrent respiratory and bronchopulmonal infections, ILD, and bronchiectasis. And with 6 years of age, it was hypergammaglobulinemia was detected, and she was treated with subcutaneous immunoglobulin, which leads to a decrease in her infections. However, the ILD was progressive. With 7 years of age, there was severe chronic oral ulcer, IBD, and failure to thrive. And the immune phenotype showed absent Th17 cells and increased phosphorylation of STAT1 in monocytes. And in the genetic, there was a heterozygous STAT1 mutation detectable. This leads to the question how we want to treat this girl with this severe manifestation. And here we do have a therapeutic dilemma in these patients. We have the possibility to perform HSCT, which offers a potential cure. But as I mentioned previously, the reported transplanted-related mortality in this previous case series was high. There's no approved targeted therapy available, especially not for children or adolescent patients. However, there is a targeted therapy available for aberrant JAK-STAT pathway, which could potentially be repurposed. And there is a different selective and non-selective JAK inhibitors commercially available. However, they are licensed for different applications such as rheumatoid arthritis, IBD, or graft versus host disease. However, there is no commercial available JAK inhibitor license for JAK-STAT EAEs. So what was the previous treatment experience using these drugs? And we do have different case reports and case series available, which were mainly smaller and had limited treatment details, so short-term, and were mainly focused on the treatment benefits. However, there is a lot of open question concerning the dosing as well, but incidence of adverse events. to close this gap and to assess the current practice of the treatment of JAK inhibitors in JAK-STAT pathway defects, we decided therefore to perform a multicenter retrospective cohort study, which was recruiting from 2021 to 2022. Inclusion criteria were a confirmed genetic diagnosis and at least 3 months of treatment with JAK inhibitor, which could be past or ongoing. Within our cohort, we were able to collect the patient information of 69 patients from different centers with a broad age range from 1 to 46. However, 3/4 of the patients were pediatric and almost 40% were 10 years and below. The majority of the patients within our cohort were STAT1 gain-of-function patient and STAT3 gain-of-function patients. Ruxolitinib was the mostly used, frequently used JAK inhibitors within our cohort, and the mean treatment observation time was 17 months. How was the treatment response in these patients? So the reported disease manifestation, you can see here in red, these are the most frequent manifestation which were reported, which is as well in line with what was previously published. We were able to show that the treatment response, the general well-being, was improved in the majority of the patients, and a vast majority showed a complete or partial response in the different disease manifestations. The same is true as well for STAT3 gain-of-function. Here we do see differences concerning what disease manifestation occurred in these patients, but in line with the previous big case series that I showed you before, we were able as well to show that the lymphodenopathy and cytopenia was the most frequently reported disease manifestation within our cohort as well. And we were able to show as well that treatment response consists of the general well-being was improved in the majority of the patients, and as well the main disease manifestation were as well improved, either a complete or a partial response in the majority of the patients. We looked as well at the patient individually, and here there's a heat map of the treatment responses in the STAT1 gain-of-function. And as you can see here, the responses can vary among the different disease manifestation, but as well within individual patients, that one manifestation can respond nicely to the treatment, but others might not. We looked as well how was the dose variation and the dose modification within the cohort. And here what we did see that there's a high variability of used concentration in all patients. There seems to be some higher doses used in STAT3 than in STAT1 gain-of-function patients. The majority had between 20 and 30 milligrams per square meter per day. The majority had 2 doses that they were treated. And more recently, more patients were treated with 3 doses, often then based on PK assessment per pharmacokinetics. However, within our cohort, we did see the decision on dose modification were mainly done due to clinical judgment in 68% of the patients, and only a small subset received pharmacokinetics or phosphorylation of STAT1 to make decision on dose modification. Let's come back to our patients that I presented you earlier. We decided as well to treat this 7-year-old girl with STAT1 gain-of-function mutation with JAK inhibitors. We used ruxolitinib with an initial dose of 50 milligrams per square meter per day, which was then increased to 30 milligrams per square meter per day in 3 doses, which was guided on pharmacokinetics. This leads to a rapid improvement of performance index, lung function, IBD, and recovery of the failure to thrive that was present before. But within our cohort as well, the other question is how does the concomitant immunosuppressive was managed upon JAK inhibitor treatment. And here what we see in both STAT1 and STAT3 gain of function, that the corticosteroids were less used upon JAK inhibitor treatment, but as well the other immunosuppressive treatment was as well less used on treatment. There were different immunosuppressive drugs used, which reflect the difference in the management and the disease manifestation between individual patient and individual center experience. When we look at adverse events, we did found that a little bit more than 60% had no adverse events reported. Nonetheless, 40% showed one or more adverse events. Predominantly, this was infections or reactivations. In these patients, approximately 1/3 were mild infections, 1/3 were viral infection. All infections within our cohort were resolved. However, the management concerning JAK inhibitors varied significantly. Some stopped the treatment, some paused the treatment, some changed the doses of the treatment. So this was as well differently used among the different centers and as well upon different infections. The second reported adverse events was the unintentional weight gain, which was often ongoing and could impact as well compliance, especially in adolescent patients. The third one, there's neurological symptoms such as headache, vertigo, concentration deficits. These were often transient, but may impact as well the quality of life on the treatment. So adverse events were common, often mild and transient. And the treatment stopped because of adverse events was in 4 out of 27 patients that stopped the treatment, and severe adverse events were rare. However, there was a limited observation time within our cohort. Unfortunately, as well, our patient suffered as well from an adverse event, an infection, mycobacterial skin diseases, which lead us to the pause of her JAK inhibitor treatment, and she received antitubercular treatment for a total of 12 months. This leads to the remission of the skin lesion, however, a relapse of her STAT1 gain of function associated symptoms. This then leads to the reintroduction of JAK inhibitors, which again showed fast improvement of her symptoms. However, we did evaluate HSCT within this now 10-year-old girl. What was the peritransplant JAK inhibitor experience within our cohort? And here we have the experience of 11 patients that were transplanted. And here, so these were 9 were STAT1 and 2 were STAT3 gain of function mutation, and they consist the whole pediatric range. And the conditioning was all patients received serotherapy, majority received Campath, and the majority of the patient had a matched unrelated donor, 6 out of 11, and all patients received ruxolitinib prior to HSCT. The outcome was 10 out of 11 are alive at the last follow-up. The follow-up time varied between 0.7 to 4.8 years. One patient deceased at day 96 with an encephalitis. Recently, there was an important publication came out from Emmeline Budding, Jennifer Leiding, and Katharina Schütz that showed the data of 36 HSCT of patients receiving HSCT, STAT1 gain of function patients, and 20 of these patients, so 56%, were on the ruxolitinib. The median treatment time was 6 months prior to HSCT, and the median dose was as well in line with what we could show as well in our cohort. Overall survival was 72%, so 84% in patients receiving ruxolitinib versus 54% receiving no ruxolitinib. And the event-free survival was 55.6%, 73% on ruxolitinib versus 30% without ruxolitinib. So the pre-treatment with JAK inhibitor was associated with a better event-free survival within this cohort. This brings me already to the summary and to the outlook. JAK inhibitors are an effective treatment for imbalance of immunity with activated JAK-STAT signaling pathway. However, are they safe to use long term? This question is still open for debate. The drug dose and monitoring varies considerably between the centers. Decisions are mainly based on clinical responses or adverse events, but rarely based on pharmacokinetics. Outcome of patients undergoing HSCT with previous JAK inhibitor treatment looks promising. However, who should we transplant and when should we transplant them? This remains open. The treatment approach and monitoring should be harmonized, and therefore an international consensus is required. And this brings me then to the second talk of Peter. However, I would like to acknowledge everyone who was involved in this work. The consensus core group, the systematic literature review team, the expert panel, but as well all the clinicians contributing patient information from their patients treated with JAK inhibitors. I would like to thank you all for your attention, and would move forward to Peter.
So I think that's now me. Thank you very much, Marco. I think you have given a great summary about what we know so far about JAK-STAT diseases and the use of JAK inhibitors. So I want to share my screen as well. Okay. So also from my side, thank you very much for organizing this webinar and for inviting me. So the part which is now on my desk is to introduce the international consensus. I think Marco already greatly introduced what we have known so far, and that there is actually a need to have a harmonized standardization what we do with these kind of patients. This is like a summary slide. It's a courtesy of Concha Campos Asensio, which is one of our collaborators. I'm going to come back to her a little bit later. Also in terms of managing a little bit the expectations. So I'm not going to give you a complete overview or detailed overview of about the 51 statements we proposed for the consensus. I think we don't have time for that. So we agreed a little bit more to focus on giving a little bit an idea how this consensus has been made, our motivation. And maybe this can also be a little bit like a blueprint for our field, where many diseases, rare diseases, are in need of have a standardized approach. So I think first of all, we start usually with a critical question, a clinical question in terms of management. I think, as I said, Marco has already introduced it with the case from Freiburg. I think we all have been in the situation that we are treating a patient with a JAK-STAT disease, and we probably think that a JAK inhibitor would be beneficial. But then when we try to give the best possible treatment, the safest treatment for our patients, we run probably in a little bit of problems. So as I said, we are aiming now to have a little bit of a guidance, because as Marco also told us, there is still a need to have a more homogeneous approach. When we talk about indications, screening, treatment, monitoring, etc., there's a lot of practical questions despite having the important data from the cohort study. So as we then decided that we need a standardized clinical approach, methodologic approach, we were thinking about what would be the best to move forward. And so we decided to recruit an international core group and then to perform a systematic literature review and apply a modified Delphi process. So first of all, what we had to do was a systematic literature review. And I don't know if somebody of you has been previously involved in a systematic literature review. So the brain of our review actually was Concha, so Concepcion Campos Asensio. She's a specialist health science librarian from Madrid in Spain. And she helped us actually guiding us through a proper systematic literature review. Why I'm saying that? Because I have been involved previously in literature reviews, but I think now, retrospectively, I can probably not say that they have been systematic. There's a lot of different methods and steps involved which are critical to have a rigorous screening of the literature and to not forget any of the papers. I think this is even more critical in our field, in the imbalance of immunity, because you know that many of our cases are, or many of our publications are case reports, which are usually nicely written, but they lack a little bit more standardization as other original reports. Sometimes there is no abstract available, which is also a limitation when you run a systematic literature review. I think the brain was, as I said, Concha, and then I think the legs and the arms were Angela from Barcelona, for example, Marco, we have met before, and Olaf here from Spain as well. With myself, I think we went to a lot of different records. More than 3,000 records were identified and then screened. We went to more than 150 full-text articles, and then we came up with about 80 studies which were relevant for our field. This is a typical flowchart of the PRISMA, so summarizing a little bit this complex methodology. And we applied the results of the systematic literature review in 2 steps. The first step was to complement the cohort study, so go a little bit beyond the information we already collected from the cohort study. There were also other case reports and case studies that were then identified through the process. And this helped then to inform the core group, and that really built the foundation for the creation of the 5 work packages and the 51 statements we're going to talk about later. Then in the second step, it was also important actually to determine which kind of grading and level of evidence we wanted to apply to our statements. And then last but not least, also to integrate the statements in the existing body of literature and also in the discussion of the consensus. So on the left side of this slide, which is also a little bit of a summary slide, you have the systematic literature review. I will introduce you also to the modified LP process. So what we wanted to do is not only collect the opinions of the core team, but we wanted to involve the world-leading experts also in the discussion and the shaping of our statements. So what we did is in the end of 2022, we had a face-to-face meeting where the core group came together with also representatives from IPOPI and also ERN representatives. We then developed the 5 work packages and 51 statements, and then we sent together with the EBMT office these statements around. So we opened a survey where 10 experts were invited. They voted on our statements, and they also suggested in a free text that was available modifications they would prefer, let's say, than to vote positively on our statements. This was then sent to another group of experts who also voted on our statements and also made slight modifications on the recommendations. And this was then fed back to the 10 initial experts to ensure internal validity of our methodology. And this was then the definitive result. As you can see on the right, as I already mentioned, we had 5 work packages which we consider to be important in our clinical practice. So first of all, the indications and contraindications. The aim was to help you to decide when a JAK inhibitor would be indicated, also to enable you to have a discussion with patients as well with the hospitals and insurance companies. The pre-treatment workup, so what to do, a suggestion what to do before you give the first pill to your patient. Then the pharmacology and dosing, which is a very specific and a little bit difficult topic in terms of to decide on what would be the starting dose, etc. Then the monitoring, so what is important to look out for when you have a patient under treatment with a JAK inhibitor. And then last but not least, also what Marco already mentioned, is how to use the JAK inhibitors as a bridge to the transplantation, how and when to taper it, etc. You can also see that we were quite ambitious because we wanted to have strong recommendations and we wanted to have a good consensus. So we decided that our threshold would be more than 80% of agreement. And I'm happy to report that most of our statements actually were fulfilling our threshold. So we had 100% agreement in more than 50% of the statements we developed, and 87.5% of it, almost half. And only 3 statements did not reach the consensus threshold. So now let's dig a little bit deeper into the work packages and the recommendations. And this is going to be a little bit like a sneak preview for you guys. So I decided to show some of the statements just to give you an idea how these statements look like in the draft. So the actual state of the consensus is that we have now a pretty definitive, hopefully, draft, which is now under consideration by the participating co-authors, and we are optimistic that probably this month we can finally submit our draft for publication. But this is a little bit how it's looking like. So we have the statements in the work package 2, so the pre-treatment workup. We made several statements. One statement, this one is, for example, looking into the baseline laboratory assessment. We also have another one for the clinical assessment that we consider would be important to perform before starting the drug. And in this case, we also produced a table which was also then voted by the experts. And as you can see, we give here a little bit an overview. So what we're looking for usually is latent infections and the basal organ status of relevant organs. Another one is then regarding the pharmacology and dosing aspect. So this is a work package 3. And maybe some of you will be, I don't know if disappointed, but the statement 29, for example, states that to date we cannot make a clear recommendation regarding the most appropriate therapeutic dose for our patients. This is not sure if this is still then the wild, wild west. So what Marco showed in terms of the variation in the STAT1 and the STAT3, I think it is not. I think we also have another statement. The next one is that the dose recommendations for other indications or published experience may be used as guidance for the starting dose. And what I'm putting in here also on the slide is what comes also from the cohort study, which have been led by Marco and by Carsten, where they give a little bit of an advice regarding how we can start the treatment in patients with JAK-STAT, gain of function, errors of immunity. And in addition, we also, I'm not showing you this, but in the other statements, we also make recommendations when we consider maybe that the dose of a JAK inhibitor should be adjusted according to different clinical situations. So I think we're a little bit beyond the wild, wild west. But still, I think there's still a lot of work to do. When we go now to the level of evidence and the grading, I previously commented on, so we use the systematic literature review, and there are criteria, the Oxford criteria for level of evidence and also for the grading. Working in the field of rare diseases, we obviously have no randomized controlled trials for most of our diseases and clinical questions, and this is then also the justification why most of our statements are actually having a low grading and a low level of evidence. This is just, I think, how the situation is at the moment. However, I think it's still important to highlight the high agreement we had by experts, international experts from different settings regarding most of our statements. But still, I think it also tells us that there's a lot of work to do. And so the question would be probably to look out, so a little bit already beyond the not yet published consensus, so what we have to do next. And I think our final aim is probably that we want to ensure the safety, the access, and the equity for patients, for every patient globally. And right now we have an expert opinion or low rate of evidence. But what we probably all want to have for our patients is regulatory grade evidence. And this is probably a collaboration which has to be between patients, science, and also industry. And this is a little bit like a proposal, what could a roadmap for consensus, could look like to move from a consensus to the regulatory grade evidence. So I think the first step was the cohort study Marco's presented. Now I think we have the foundation with the consensus guidelines. I think these are going to, or I hope these are going to be helpful for all of you. I think now using a tripartite collaboration between patients, industry, and science, what we really should look for is to perform prospective clinical trials, which are still the gold standard in our field, and which should be our final goal to give the best medication and the best management to our patients. So as I said, I think this collaboration is going to be very, very important, and there are some proposed next steps. So as I said, right now what we have is retrospective data. I think we have made a good effort to identify all the evidence that has been published in different case reports and cohorts. But probably what we now need is, if we want to create statements with higher assumptions or recommendations with higher grades of evidence, then we need prospective data. This could be a prospective cohort, or, which would be probably best, international clinical trials. And maybe you would say, okay, this is so complicated, it cannot be done. I think we have now also in our field, in diseases, clinical trials which can be performed, which can be, for example, a basket trial or something similar. But I think when we try to engage in this endeavor together as a field, I think this is possible, and I think this should be something we should work to. And this is already my acknowledgement slide. So similar to Marco, I also am very, very grateful to all the colleagues who have been contributed in the core group, the people also from IPOPI, from ERN, the systematic literature team. I didn't show you the photos. I had some photos because the process was very, very tedious, and it was very, very important workload. And also our experts who were very, very helpful in order not only to vote on our statements, but also to help us finally shape the statements in the definite version they are right now. And yeah, that's it from my side. Thank you very much for your time, attention, and we're happy to take your questions now and discuss.
Thank you very much, Peter, and also thank you very much, Marco. I think there was a really deep insight into this topic viewed from various angles. I personally also like to thank you two for really joining me in these study efforts, and I think it's two nice projects that really build up on each other. So I also like to thank ERN-RITA for providing us the opportunity to view on this topic in this broader community. Actually, when I checked the numbers of participants while you were talking, there were peak times more than 100 colleagues out there. So thank you also everyone for joining us, showing this is a topic of great interest, and there's still almost 100 participants in there. So for the remaining minutes of this session, we would like to invite you to discuss issues that you would like to dig into deeper, that maybe based on the talks you just heard, or also other aspects that you want to discuss on the use of JAK inhibitors for inbound errors of immunity. At the moment, there are only 2 questions in the Q&A, but please, if you have questions, type them, and I will get started with the 2 that are there, and maybe find other issues to discuss with you too. So the first question that is in the Q&A is tackling points on finding the right dose for JAK inhibitors in patients who may develop side effects. So question is, increasing the JAK inhibitor dose to improve efficacy is not always an easy decision, because some patients may develop side effects. What is your advice on this? For example, a STAT1 gain-of-function patient with CMC, azole resistance, and bronchiectasis with chronic bacterial infections. So I think the question is probably how to dose if you suspect side effects, but maybe also the difficult decision, what is side effect and what is disease, which is also sometimes difficult, I suppose. Marco, do you want to give it a start? How to dose if you think your patient has also potential side effects? Because you have a nice patient example where you also discussed this a bit more in detail.
I think it's important to have objective measurements, because the clinical response is sometimes difficult to judge. And therefore, especially as well in patients that receive as well also maybe other treatment as well, antifungal treatment as well, I think it's critical to not just rely on the clinical responses, but use as well pharmacokinetic to assess that you are in a adequate range with your treatment.
Yes, I fully agree. Maybe you just can't comment on this very briefly, because this is something we are often addressed when we have talks on this topic. And I think one bottleneck certainly is that PK is helpful, but it's not readily available. I think that is something really. So if you refer patients to larger centers experienced with these drugs, many of these will at least have access to partner labs to assess for also pharmacokinetics. And I think in the end, for every patient who is on these drugs longer term, and certainly if there's any uncertainty whether patient may have side effects, or also if you may be considering the drug is not working sufficiently, it is very helpful to look into the PK, whether you have high levels or sometimes even maybe not sufficient levels, in particular in very young children, where we learn that they are fast metabolizers. Peter, you also want to add a comment on this particular point?
Yeah, just briefly. I think it's super important to also talk to the patient and to the family and agree on a treatment response which we would like to achieve. And this is sometimes not easy, but I think most of our patients, I know they are complex and they have maybe two or three things we have to address at the same time. But I think it's important, for example, to say, okay, let's try to treat this treatment-resistant candidiasis, and then when we have achieved that, then we can go from there. But I think it's very, very important because, as you said right now, although you have access maybe then to PK levels, this is not going to be something you have in a turnaround time, which is very, very easy then to manage, even in the outpatient setting. And on the other hand, actually, we don't really know what the best levels are yet for different indications. Maybe for CMC, we need, I don't know, whatever level, and for cytopenias, we need something completely different. I think this is super important to be honest to the family and say, okay, let's try to make this better. And when you talk about CMC, I think CMC is a very interesting and difficult disease. And if you have already a azole resistance, it's also very interesting to get help from your infectious disease specialist, because maybe there are some options you can also consider in order to at least give a little bit of supportive care also for the CMC.
Yes, I can maybe have one aspect, and then we on PK, and then we come to different questions, because there was another question coming up, basically building up on Peter's comments, which is, when using PK to support decision regarding dosing, what are the goal trough levels or other goals? And maybe I can add to this briefly. As Peter said, there is we don't know for sure what is the level we are targeting, in particular for also the different diseases and the different manifestation. But what we can assess is, first of all, does the patient build up a sufficient level based on other indications? So this has been established, for example, in GVHD. So levels that are sufficient to control inflammation and GVHD. And also you get an impression on, if you do an AUC, how fast your patient is metabolizing the drug. So you get an idea of the over the day exposure. So saying, if you dose 2 times a day and you give the drug, and you can assess in the PK that all of the drug is gone after 2 hours, you're likely to be insufficient in your dosing, as you have the patient most time over the day without drug exposure. So this is in particular in young children what we learned, where we now often start with dosing 3 times a day with ruxolitinib instead of 2 times a day that we did in the past, because we see in many young children these fast metabolizers. So following recommendations established for other diseases and individualize also the over the day exposure is something you can work into. And also the platform you assess PKs on are different. So I think you have to discuss this with those people treating more of these patients where in their local cohort, they have made good experience of achieving sufficient symptom control. So there's various viewpoints on PK also aside from the general trough level, as you would maybe have this for other immunosuppressants in other indication where you have clearer cutoffs where you want to have the patient's levels. Then there is an interesting question. Maybe Peter, you can comment on this because I think you also have patients with similar clinical problems, and this is regarding the vascular pathology we see in some patients. And the question is, what can we offer for patients with cerebral aneurysms or other STAT1 gain of function associated vascular pathology? I suppose in terms of treatment in general, this is not specified here, maybe also monitoring. What would be your clinical and treatment approach, Peter, to this, or maybe also monitoring approach?
Yeah, I think this is a very tricky question. I mean, I know I've also seen it in the Q&As, and I know it comes from Jan. I think I know the patient as well. And I have also my first STAT1 gain of function patient actually presented with cerebral hemorrhage, and then she was diagnosed with the STAT1 gain of function. This is one of the manifestations that has not been, where we not have been able to find actually an improvement under JAK inhibitor therapy, which is also maybe due to different reasons, such as if the damage is already established, maybe you just cannot go back. There is some interesting animal data regarding the development of, to protect against the development of aneurysms. I think it's in mice, or yeah, I think it's in mice, under the use of JAK inhibitors. So potentially there might be something that you can trigger the vasculopathy when it's an inflammatory vasculopathy in these patients, but it's really not. It's a little bit frustrating. If you go through the literature, most of these patients, they do not show like a treatment response. In our specific case, what we do is a very close follow-up. We work together with the interventional radiologist. So these patients need more, at least for now, in terms of treatment, which is beyond pharmacology. Yeah, I think that's more or less what I can share about this.
Yeah.
In terms of what you need for the monitoring, I mean, what we do in our institution, I think this is also something we address in the statement. Maybe before starting or diagnose your patient with the STAT1 gain of function disease, let's say, to consider to do also a screening to look for at least cerebral aneurysms or vasculopathy. And then if you have also a low threshold, if you suspect vasculopathy in other organs which may be affected. And then during the monitoring, so of course, if you have found something, then I think the clinical picture is dictating when you have to repeat your imaging. And if not, I think, I don't remember it right now if we put something in the statements. I don't think so that we were very concrete on this aspect. But what I would probably suggest is probably do an MRI maybe every 2 years or something like that if there's nothing specific coming up, like a headache or something like that. Yeah.
Yeah, that's what we also at least do where we usually start with MRI imaging, latest in teenage year or in every patient that has also a significant disease burden. So multi-organ affection, then also younger, and also in a patient that not significantly infected latest before transition, so that we clearly have a look at all possible critical organ manifestation of the disease. And I think that includes also vascular imaging. Jan specified his question on the vascular pathology, stating that HST is probably also to have a positive effect on vascular pathology, including calcification. I think my personal opinion would be, I would hope for this, but I think we don't know for sure. I think, Peter, also one of the issues that we have difficult to discuss this in the consensus is that although we are aware that this is a very specific presentation in STAT1, it's still rare, also in the published cases. So it comes down to very small patient numbers. I mean, ideally, when you transplant a patient, you would hope the patient doesn't have yet a vascular pathology, because vascular pathology certainly puts the patient at a higher risk if you have this pre-transplant. Whether transplantation long-term prevents vascular issues, I think something can be hoped for, but we don't know for sure. Catching up maybe with some HSCT related issue, there has been a question regarding pre-market data that you've shown, and maybe we need to specify this also in terms of previous transplant data in patients transplanted without previous bridging therapy with a JAK inhibitor to now newer data that you analyzed in your study, but that's also in particular been published in a very recent study under guidance by Katharina Schütz, the improved outcome actually under previous JAK inhibitor bridging therapy. The question is, what is the likely explanation for the high mortality in patients undergoing bone marrow transplantation for these disorders? Can you comment, Marco? I can also help you out if you're uncertain.
Yeah, I think it's the hyperinflammatory state that these patients having running into and this we can see as well from other HSCT treatable diseases, that it's always good to treat the hyperinflammation prior to going into the transplantation. But you as a seasoned transplanter has maybe some additional insights.
No, I think, well, that's certainly the key aspect. So at least, again, from small patient numbers, you were citing this initial cohort study that indeed showed significant mortality. And if you look into these studies, that's the theme that Marco just mentioned, that is quite homogeneous, this early hyperinflammation leading often to a rejection and graft failure in these initial transplants. And indeed, was data is, I think, quite clear in the very recent and larger transplant series that pre-treatment with a JAK inhibitor in many patients silences inflammation, improving this hyperinflammation associated graft failure. And I think one can state that if you have a patient with good inflammation control, outcome is nowadays similar to other immune dysregulatory inborn errors of immunity. Again, pre-transplantation disease morbidity assessment is crucial to identify potential risk factors. That includes a situation where there's chronic viral activation going on, vascular disease. But I think it's a completely different option nowadays with these drugs available, and finding the right balance of whom to treat, for how long, and whom to transplant is still something we need to explore deeper. And as Peter pointed out, ideally in prospective trials or registries for these conditions. There are questions regarding other pharmaceutical compounds that may be attractive to be used in these conditions. As both of you are very familiar with the literature, maybe you can give a hint whether there's experience, at least from case reports, that I am not aware of. And one question is whether interferon blocking agents, what I suppose also meant is interferon gamma blocking agents, and for example, also use of imapalumab could be beneficial in the management of these diseases, particularly in STAT1 and STAT3 gain of function. I'm not aware of case reports using imapalumab. Have you came across this in your literature search? Marco, do you know?
I mean, the problem is that, or not the problem, but the focus and scope of our literature research was JAK inhibitor treatment, and that's why it was geared towards that. So patients just treated with interferon blocking agents alone wouldn't show up in our systematic literature review. That's the first part of the answer. The second one is, as I stated in the introduction, I mean, the JAK-STAT pathway is so important in so many different cytokines that I think a really targeted treatment towards one or the other is difficult due to the broad effect, and that's the beauty as well of the JAK inhibitor treatment, that it really targets the treatment in a broader sense.
Yeah. Okay. So yeah, and this is maybe I'd like to pick this up also as one last question. Again, I already know there's still a lot of uncertainty left, but that is in regards to the selection of which JAK inhibitor to be used. I mean, maybe I start with a comment and then I hand the question over to you, Peter. I mean, we've also been talking a lot about ruxolitinib, and that is simply because that's most reported treatment experience available. And that is probably likely because this compound has been on the market for a long time, and we use it for other indication. We know how to then handle this, and also PK is available, at least at some institution, which is not readily available for other compounds. And the questions that comes up here is whether you could imagine that a JAK1, so not JAK1, JAK2, but JAK1 selective inhibitor could also do the trick. Could that be helpful to reduce adverse events, or would you think response is not enough? Again, I already stated we probably don't know because there's not enough data out, but what is your thought on this? What would you pick if you had any drug available? Peter.
It's funny that you're smiling after making the comment and then handing over the question. Yeah, I completely agree with you. I think the basis to start actually with ruxolitinib, many of our patients, was just because the case reports were stating ruxolitinib is working, and then you say, okay, I don't have any idea, but this has apparently worked, so let's start with ruxolitinib, which is more or less available. In pediatrics also, it's sometimes a little bit easier to dose ruxolitinib because there are also some liquid preparations available that has been developed mostly for graft versus host disease, which is also nice, instead of baricitinib, for example, where you're a little bit more limited in this sense. So this is my comment, and now to try to answer the question. I think theoretically it would be interesting to just block JAK1 and see what happens, but I cannot really envision if there would be something missing if we do not block JAK2. I think we also have to recognize that when we talk about selective inhibitors, many of them are not that selective at all. It also depends on the dosing, and then when we don't have really an idea what the perfect dosing is, I think we don't really can anticipate what the selection of a specific kinase is. So I think the question is great, but I think the answer, we're probably far away yet still. And I mean, the only way to really answer these questions is first probably to have a nice animal model. I know there are some STAT1 gain of function models out there also for relevant mutation, for example, the T385M mutation is available as an animal model, but I'm not aware of any preclinical data using, for example, a JAK1 selective inhibitor, but that would be, of course, interesting. And then, as we said, I mean, there are probably coming out case reports where people try to use these kind of drugs, maybe more frequently. But I mean, we're talking about numbers like maybe 2 patients, 5 patients, and to draw really conclusions from this, I think it's not possible. So
no, I mean, your last slide, you showed how sort of these two study now are first 2 steps of a fundament to build onwards, ideally to randomized controlled trials. So and also cooperation that would be lovely to have with companies to address these in randomized controlled trials. So maybe that's hope for the future, that we can show in such webinars that there is a great need, great patient numbers, that we need to explore these questions to improve these therapies and to make them safer. So again, I'd like to thank you too for your contribution, for the lively discussion. I'd like to thank the audience for the interesting question time. And Maud, I think I hand over to you for some general closing announcements. Thank you, everyone.
Yeah, thank you. So on behalf of ERN-RITA, so we would like to warmly thank our speakers for this excellent section and for the great discussion that followed. So we would greatly appreciate your feedback. So please take a moment to complete the survey that will appear when you close the webinar. So thank you again for attending.